Hello and welcome to Duty 5 Knowledge. So in here you can see in Canvas we've got our overview, your PowerPoint, we've got the information and we've got our knowledge requirements. So we're covering knowledge 18, 19, 20, 21, 22 and 23. So let's start off with here. So you can see the skills are here and the behaviours, and we'll be doing those next week. So here we're looking at how to build a rapport with people and groups to collect information about their health and wellbeing concerns. How to acknowledge and respect individuals there. Look at behaviour change principles and theories that underpin health improvement activities. Evidence-based behaviours, looking at and tools and techniques. So we've spent quite a lot of time on that now, haven't we? The concept and theories relating to engagement, empowerment and co-design and person-centered approaches, and the difference between enabling people to make their own changes to resolve their own problems. Good, so quite a lot here. So you've got a PowerPoint presentation here just to go through. I'm not going to go through that today. We can have a look at that maybe another time, and then we're here. So we'll start here. So Duty 5 looks at applying behavioural science to help people find practical solutions for better health and well-being. So if you've never heard of the term behavioural science before, hopefully by the end of the session you'll have an idea of what that means. So an introduction here, Duty 5 involves applying behavioural science principles to support individuals to find practical solutions. And we spoke about that, didn't we, in the last session. We talked about solution-focused therapy and acceptance and commitment therapy, CBT, cognitive behaviour therapy, and DBT, dialect behaviour therapy. Behavioural science provides valuable insight into understanding human behaviour, decision-making processes and influencing lifestyle choices. By harnessing this knowledge, professionals in healthcare and related fields can design interventions that effectively promote health and well-being that lead to positive health outcomes. Now, if you've never done behavioural science before, you can go to the mental health nurse course box, you can log in and you can do the behaviour science CPD module for free of charge. You can get your certificate in behavioural science. So it's there. You're allowed to do that as one of our students. So log into my mental health nurse channel course box, which you've been given the links to, and you can do the behavioural science course there. But understanding behavioural science is an interdisciplinary field that combines elements of psychology, sociology, and economics, and other disciplines to studying human behaviour and cognition. It explores how individuals make choices, respond to incentives, and interact with their environment. Applying behavioural science to healthcare fields allows practitioners to tailor interventions that resonate with individuals' motivations and preferences, increasing the likelihood of success of behavioural change. So there's also a technique called motivational interviewing. Again, if you've never done that before, I have got that in the course box courses, so you could do that there. And we do cover motivational interview on the YouTube channel as well. So there's lots. I mean, you could just keep going as deep as you want on this. Identifying behavioural barriers. One of the primary challenges here is promoting better health and well-being. So let's just reread that sentence because it's so simple. One of the primary challenges here is promoting better health and well-being. Well, we've got all of these health promotion tools. The trick is not to make it look like you're lecturing somebody, but you have all the tools. And when we keep saying we need to invest more, we need to do this, I'm a little anti that as a mindset. We have so many health promotion tools. We just need to use them. We have smoking cessation, alcohol reduction, eating well, 0 to 5K. We've got drugs and alcohol advice on TV. We do the don't drink and drive at Christmas campaigns. We've got know your blood pressure score for statins. We've got know your score for diabetes. I mean, we do so much health promotion that actually it's not difficult for you to have all of that. And we've done that, haven't we? Look, it's here. Toolkit for health promotions. I've put it all there for you. just learn it, have it available, have it on a fact sheet that you can give to people and say, look, did you know we've got all of these resources that you can use? We don't need to reinvent wheels. That's what I'm trying to passionately get at here. We don't need to reinvent wheels. Okay, so equally, we need to think about then promoting well-being. So again, promoting well-being isn't difficult either. We're not asking you to change the body. We're asking you to give health education. So you can just give somebody the link to my YouTube channel. You can get them to do a bit of mindfulness with you. We can get them to a bit of square breathing. We can get them to do a bit of rest and relaxation or guided meditation or self-help. We can get them to do self-referrals to IAP services. It's all there, isn't it? It's all there. It's all there. We have it all. We just need to bring it together. Don't get me wrong. We need to also identify the barriers that hinder positive behaviour change. Okay, so there will be barriers there. These barriers may include lack of motivation, fear of failure, social influences. So, if people around you are drinking, why would you give up drinking? Or again, ingrained habits. So it's not as easy as I've probably just made it sound. There are definitely barriers, but if we know some of those barriers, we could work with taking some of those away. We can look at solution-focused therapy. Okay, so your friends are always coming around your house drinking and you'll find it difficult because you're trying to abstain. What is it we can do here? And hopefully they'll say, oh, well, maybe I shouldn't be inviting them around anymore, or maybe I shouldn't be doing this, or maybe I shouldn't be doing that. Okay, great. Solution-focused therapy. You're coming up with your own solutions. By conducting a thorough assessment and employing behavioural science research methods, practitioners can pinpoint the barriers and design interventions to address them effectively. Exactly. So, behavioural science is all about understanding why we do what we do, the psychology, the sociology, and the economics. So what I'm thinking and feeling, what my upbringing has been, and my demographics. And if we can understand that in a non-judgmental way and provide the support, this person will have much better outcomes. Implemented behavioural change models. So again, utilising nudges and incentives. So nudges are a suitable change to the environment that changes individuals to make healthier choices. So if you've never done nudge training before, again, you go into my course box, you can do nudge training. But nudge training is just, look, here's some information. Maybe that's helpful. I'm not telling you, because if I tell you something, I limit your choice, I take away your autonomy. I need you to do this by yourself. Behavioural science helps professionals identify and implement nudges that positively influence decision making. So again, that could be things about placing healthier food options, all that subliminal messaging that goes on there. So let's just think about what we can do to adopt behavioural science to the things that we do. So rather than me telling you, what can I do to assist you? Rather than me making you feel bad, what can I do to make you feel better? Rather than talking at you, what can I do as motivational interviewing? How can I make you feel empowered? Rather than taking the horse to the water and trying to dunk their head in it, why can't I just point to the water and say, look, it's over there? And hopefully allow you to do that. But I need to know those barriers. I need to understand what those barriers are. Implemented behavioural change models. So understanding change models is really important. So behavioural change models provide frameworks for understanding the stages. Again, if you've not done behavioural change before, there is a course in course box that you can do, or you could just do a bit of research on behavioural change. But for example, there are models out there called the transitional model, or trans theoretical model, or the health better models. These models help practitioners to tailor interventions to individuals' readiness to change and assess specific challenges associated at each stage. So the health belief models look around things probably more on substance misuse, about Are you ready for therapy? Are you ready to engage? One of the barriers that we have for a referral for substance misuse is if you're on substance misuse, excuse me, if you are currently using, then you might not be ready for therapy, but you need therapy to come off, and it's just a ridiculous cycle. Something has to give there. So again, just have a look at research in your area. Utilising technology and digital interventions. So again, if you are not technology savvy, I do a YouTube channel for digital skills. So go on, have a look at those digital skills. Look at the apps on your phone, look at wearable devices, look at how we can track progression. And digital technology gives feedback in real time. So again, it really does facilitate behaviour modelling and behaviour motivating and empowering people to take a more active role in managing their health. Empathising and communicating. So empathy and effective communications play a crucial role to facilitating behavioural change. Practitioners who apply behavioural science to their practice must cultivate a non-judgmental and empathetic approach when interacting with individuals seeking support. Understanding their unique perspective, values and challenges, allowing practitioners to tailor interventions to align with their motivational and priorities. Now, being non-judgmental is far easier than what we say. So I'm sure I've told you the story of when I was a student nurse, and there was this lady who had injured herself, and she was hobbling across the board, and everyone was ignoring her. And I went up to her and said, you know, what can I do to help you? She kind of burst into, oh, you're the first person to offer me help. And then when I sat down with a cup of coffee, and I said, let me grab that for you. We'll have a little chat. I said, tell me what's going on. What I can see you're upset. I can see you're in pain. What's happened? And then she told me something really horrific. The next day, I walked straight past her. Now, I was a student at this point. I went to have supervision. I knew I'd done it. And I went to my psychotherapist and said, I think I need some supervision. I've done an awful thing. So that I've been really judgmental. I can't now shift it. And my psychotherapist was like, so you're human then? He said, we're all judgmental, Steve. He said, but it's what you do with it. He said, and the fact that you've recognised it is brilliant. He said, because now you know that you are non-judgmental. He said, it's when we're in denial. He says, when we don't think we're non-judgmental, that's the problem, because then you've probably got those biasness hidden away, or you may be doing it in some kind of auto behavior. So to me, that was fascinating. And now I recognize it, but it means that I have to work hard. And it also means I have to develop a much richer, stronger poker face. So if somebody tells me something, I think, ooh, that really grains against my value and belief system. I have to kind of hold on to the fact that, okay, fine, that's my value and belief system. That's not necessarily yours. I don't understand your life. I don't understand why you did what you did. I don't understand the choices that you're making. So actually, I need to cultivate that non-judgmental approach and be a bit more empathetic and human towards what's going on. And what I tend to do to ease my own conscience sometimes is go, you must be in a very strange, dark place to have done that in the first place. And that's the bit that I try to hold on to, that human connection. And that allows me to then more have natural empathy than avoiding what's brought you here, if that makes sense. Evaluating and adapting those interventions. So to ensure that the effectiveness of behavioural science-based interventions, continual evaluations need to be adapted, collect data. So when collecting data and measuring outcomes, in psychology, we use a score called the SUD score, situational units of distress. It's between 0 and 10. So 0, I'm not in distress. 10, I'm in masses of distress. Could be the other way around. Can't remember off the top of my head. But anyway, whatever they say to you, we need to be as closest to the no distress. So if somebody tells you they're in a lot of distress, so start the conversation, between 0 and 10, how much distress do you think you're in? I'm an 8. Okay, well, that seems quite high. Can I just ask, why are you an 8 and not a 9? Oh, I'm not that distressed. Oh, okay. But why an 8 and then not a 7? So trying to understand why they score what they score. And once you've spoken to them, and once you've given them the help, and once you've given them resources, and once you've given them the interventions, then ask them again, just out of curiosity, how do you now feel between 0 and 10? Oh, I feel like a 4. Great. So you've come down 4 units of distress since talking to me. And that does 2 things. 1, it means your interventions work. And 2, it gives you the assurance that when somebody leaves you, you're not leaving them in a huge level of distress. So that risk of suicide, self-harm and whatever, you can say on your notes, when they left me, they started on a score of 8, but when they left, they was on a score of 2. And therefore, that's quite a distance down that you've bought something to keep them safe. Hopefully that makes sense. I'm not waffling there. But situation units of distress are really helpful. It's an outcome way. And again, you can then say, so last time I saw you, you said you were a 2 or a 3 and you've not been sleeping, you've been really stressed. And I'm just wondering, we spoke about sleep hygiene. We spoke about some changes in your diet. We spoke about maybe that substance use. I'm just wondering, did you manage to do any of that? Oh yeah, I start to get better sleep. Okay, great. So if you were now to measure your units of distress, what would you grade that? Oh, a 1. That's fantastic. So those interventions are working really well for you. Yeah, great. So again, it's a very objective way of measuring. Granted, it's objective from their point, but from your point, you can see that your interventions are working well. And then evaluate and adapt those interventions. So just making sure that, ask them, is that working? No, it's not really working. Okay, what do you think we could do to tailor that? What can we do? So it's this constant negotiation and working with them. So when we think about building rapport and, managing groups and eliciting information for their health and well-being concerns, we want them to feel that we're listening to them. So active listening is truly the skill here. And there's a great process. It's used in adolescence child care, but I've used it in everything. And actually, even when I used it in my OSCEs for my master's and for my degree, I scored the highest in the year group for my OSCEs here. And basically, I used a process called Davis's structured interview techniques. So it's David's structured interview techniques for adolescents. And he talks about 3 things in this. He talks about logging on, maintaining, and logging off. So logging on is, hi, Steve, I wonder what's brought you here today. What's the most important thing I can do for you now? So you're allowing this person to tell you what's on their mind, to feel heard, to feel validated. Okay, great. Then maintaining is holding their interest, allowing that conversation to flow. And to allow conversation to flow, we just simply do all the W's. Okay, that's interesting. What do you mean by that? Okay, when does that happen? Do you know why that might happen? What helps you in those situations? And then at the end of your discussion, thanking them and logging off. And logging off, you must log off with this phrase, which is, thank you for today. I'm just wondering, is there anything else you want to tell me? And what that does, it invites them in for anything else that you haven't allowed in that interview or that conversation. So it may be that this person was dying to tell you something. The conversation went one way. It went the other. You've summarized and said, all right, thanks. Great. We'll see you next time. And that person, oh, damn, I wish I'd asked that. Or I wish I'd said that. Just by saying, I'm wondering, is there anything else you want to tell me? You've given them the opportunity to be heard, and that creates a safe, supporting, and open relationship. So use Egan's style of communication, so solar, sit opposite, open, lean in, nod, agree, and use Davis interview structured techniques. Log on. What brings you here today? What's the most helpful thing that I can do for you right now? allow that conversation to flow. Great. Tell me a bit more about that. What is that? When does that happen? Why does that happen? How does that happen? And what normally helps you? And logging off. Thanks for telling me all of that today. I'm just wondering, is there anything else you'd like to tell me? Perfect. Perfect. Tick, 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 tick. Empathy and understanding. So demonstrate empathy and understanding towards people's feelings. Now, again, there is nothing wrong with saying to somebody what you see. Now, if you're sitting in solar, so you're sitting opposite, so I'm here, you're there. My eye contact then allows me to give you good eye contact, but it'll be a bit weird if I just keep staring at you, but I can see your whole body. And what that means is, if I see you clenching your fist, if I see you tensing up, I can simply say, look, Steve, I can see you're a bit tense. Do you want a glass of water? Shall we just go and get a bit of fresh air? Just go to the window. Because what you're saying to that person is, I'm watching. I'm paying complete attention to everything you're telling me. If you can see somebody welling up, getting a little bit upset and emotional, have that box of tissues ready. Look, my lovely, I can see you're upset. Because there's nothing wrong with saying to somebody what you see. Never say what you might think they feel. That's dreadful. Steer very clear of that. Oh, I know what you feel like. No, you don't. So never say that. But you can always say what you see. I can see you're upset. I can say, oh, no, I'm not, honestly. Okay, that's fine. But they still know that you're looking. Be respectful through that conversation. And obviously logging on, allowing people the time to talk, asking those open questions and then logging off allows that time. Whether that's a physical health problem or a mental health problem, it's exactly the same process. Establish common ground rules for interests. So again, fostering that sense of shared understanding. And again, I always say to people, look, this is where we're at. This is the support I can give you. These are the tools I can give you. I can help you as far as I can. But if you're not honest with me, if you know, things aren't working and you're not telling me how, it makes it very difficult for me. But equally, you may have to have some ground rules. So if somebody starts to get a little bit angry and a bit sweary at you, depends on your tolerance level. Now, I know the NHS has a no anger shouty policy. I struggle with that in mental health, because in mental health, the reason they're with you is because they're not able to manage their feelings and emotions. So it's very difficult for you to then start going, you need to manage your emotions. I'm not going to help you, because that's patronizing. What I tend to say to somebody is, look, Steve, I can see you're getting upset. So what I'm going to do is I'm going to give you 5 minutes. Do you want me to get you a glass, or do you want a cup of water or something to help calm down? I don't need to enter in an argument. I don't need to enter into this whole, you know, and if you swear at me, I'm kind of a bit like sticks and stones. I may need to do a boundary check. I may need to say to them, look, I don't mind you swearing. I don't mind you getting upset. I can't, you know, the line becomes that aggression. So if you come towards me, if you threaten to hurt me, that's the line. And there have been many times I've said to people, that's the line. You know, I don't mind this bit, but we have to have, you know, you can't threaten to punch my colleague's head in. That's the line. I don't mind you swearing, because that just doesn't offend me. But you threaten to kick my colleague's head in, that's the line. But again, depends on your policies and your levels of resilience. And what I tend to find is, I used to get all of the challenging people. So once you've done your training for challenging, hazardous and managing behaviour, if you haven't done it, the good news is you can do it with us. It is a course that you can do, but it's not managing challenging behaviour. Okay, so let's get that one out the window. It's not a half-hour DVD on how to watch signs of escalation, de-escalation. Managing challenging and hazardous behaviour is a 3-day course. In it, you learn safe hold, you learn restraints. You need to be able to maintain your own safety. So if you need to do that training, just say to me, Steve, I think that training would be really useful. When and where can I go on that training? And I'll let you know. Because ultimately, you need to feel safe. You know, I don't want any of my students managing people where they feel intimidated. And quite frankly, when we talk about risk, people with mental health, who have a history of aggression or harm, it is risky. So just be mindful of that. Build trust, build a nice relationship, look at cultural sensitivity, personalize that communication, empowering your language. So that's motivational interview techniques, non-verbal communication. So again, just lots of looking, and again, be mindful of the smiling. I have been accused a couple of times of being too cheery or too happy. And am I enjoying what I'm seeing? And I hadn't realised that I was smiling at the time. So I tend to kind of feel like that. So I'm not happy nor sad. I kind of have that vacant expression. But what I have is the look. So my eyebrows may go up, I may nod, and I may accept things. And I always follow up with support. So understand, or how to acknowledge and respect individuals' priorities. So this one's really interesting, and I've seen it done really badly over the years. How to acknowledge and respect an individual's priorities in relation to their health and well-being, and understand their right to refuse advice and information. So this isn't difficult for me, but I'm going to try it and not lecture on this one. But people have the right to refuse, and people have the right to make unwise decisions. It is not down to you to lecture somebody about the choices that they make. So, for example, I do not want to hear things such as, well, no wonder why your cholesterol's high, look at what you're eating. Not helpful. I do not want to hear from anybody, well, simple, just stop it. I've heard, how many times I've heard to alcoholics, just stop drinking. Well, if it was that simple, we don't need drugs and alcohol services, do we? We then have our quality targets, so our QIFs or whatever they're called. Because we're paid by the government to push the smoke agenda and the alcohol agenda, what nurses and clinicians end up doing is lecturing somebody who's in a crisis about, well, you really need to give up smoking. Did you know that smoking can make you feel depressed? Is that really a priority for that individual right now? Is it? Is it? Come on, people. So, yes, we have the tools. Yes, we have all the health promotions. But let's just be proportionate about and sensible when we apply this knowledge to somebody, you know. And if you can't fit it in and you've got to tick a box because you've had that conversation, then can I just say that you have it as a leaflet and you give it to them as a leaflet and go, look, I know now's not a good time to mention this, so I'm not even going to mention about smokes and sensation and the fact that you should be given. I'm not going to mention it. But what I'm going to do is give you a leaflet and pop it in your bag, if that's right. And when you're ready, have a look at that at a later date. And if you want to talk about it, let's talk about it. But I do not need to launch into the risks of smoking. You are an adult, you know the choices, you know the risk. You know, if you're sitting there crying your eyes up because your relative's just passed away or you're in debt management or whatever it is, we just need to apply a bit of common sense to this. So we just need to think about how we do this. So what the agendas are, what we're trying to push, what the health promotions are, is it appropriate? And again, if we start pushing smoking, does that come across as judgmental to somebody who's unwell? So I tend, if I have to have the conversations with people, when I do, I tend to go, look, no, I'm a non-smoker. I've never smoked, but it doesn't bother me. It's your choice. However, I do need you to know the risks. They are this. Again, likewise with drinking, I am certainly not going to give my opinion on anything because I have to respect people's right to autonomy, their right to choice. Whether that is pro-life abortion, whether that's the right to treatment for cancer, whether that's people wanting PrEP for sex, whether that's drugs and alcohol. I'm not there for that purpose. So just please be mindful about that. Shared decision making. So again, we can talk about third-party organisations. So maybe we've got organisations down the road. So again, for example, in Hastings, we've got Change, Grow, Live. So do you want me to pass that information on to them for you? Would that be helpful? Blah, blah, blah. Again, cultural sensitivity. So just thinking about the conversations that you're going to have. Are they relevant and appropriate? So, for example, if we're going to be talking about blood and plasma, are we making sure that we're having those conversations with the right people? Health literacy. So making sure that people have health literacy and the information is in the manner that they can understand. So think about accessible information. Are you going to give them a leaflet? Are you going to give it to them digitally? What frustrates me greatly is one NHS Trust Foundation will have beautiful literature on mental health, beautiful literature, because I'm not allowed to signpost you to it because that's not allowed. But if you Google a library of information for mental health, you'll come up with like a bookshelf, and each book will have something like depression, and in that book it will go, here's your book, it's in an easy read format, it's in a video format, it's in an MP4 format. Perfect. Now, one trust has spent tens of thousands of pounds of public funds making all of this, and then they copyright it to their trust. So you need to be careful what you're referring to. However, if you find it online and you find things that are useful, then obviously you can use it for your knowledge and understanding. You couldn't necessarily recommend it, which is very annoying, but you can adapt it for what you need and be very loose with that. But please don't copyright stuff, because I don't want you to get into trouble. But when you look, there are some beautiful things such as the mental health bookcase out there that you could have a look at that I'm not referring you to. Confidentiality and privacy, so just being aware of those things. Respecting the right to refuse, so again, just be mindful of that. Continuity of care, so maintaining what that looks like, what happens if you're off, etc. That could be a real problem if you're really good at your job. People are going to go, oh no, can I speak to this person? So we don't want to create reliance, because we're all about autonomy and promoting independence. And again, then your reflective practice, so what's worked well, etc. K20 then looks at behavioural changes, principles, theories that underpin health improvement activities. So this is the behavioural science. So again, all of these you can find on Coursebox through the Mental Health Nurse CPD. But you need to learn a couple if you don't want to learn them all. You've got the health belief model. So the health belief model looks at the likelihood of engaging in activities. You've got the theoretical model, which is stages of change, so understanding the contemplation, actions, maintenance. The theoretical model of, the social stages of change model. Again, it's a useful model to how the likelihood is, or what the likelihood is for somebody to engage. So if you think about your referrals and your points of referral, that's useful. It may be the fact that you need them a bit more on the change model before we refer them, because that costs money, etc. The social cognitive theory. So look at the social cognitive theory is the interactions, so observation, modeling, and shaping behaviour. So be mindful of that one when you're managing health and well-being. You know, if you're sitting there as a negative Nelly, guess what's going to come back at you? If you're sitting there super hyper and super positive, that may be a little bit too much for people. So be mindful of that projection, deflection, and all of those things there. The theory of planned behaviour. So the theory of planned behaviour suggests that individuals' interactive and engaging behaviour influence their attitudes, behaviours to the subjective norms. So again, that's a useful theory. So again, go through these, understand them, pick a couple that you really like. So CBT, cognitive behaviour theory, is an absolute must for anyone that works in health and wellbeing, because it is what the IAP service do. So for you to be able to explain CBT to somebody is a really useful thing. I tend to use an analogy of buying a coat or something. So thoughts, feelings, behaviour. So you're walking past a shop and you see a coat in the window, and before you know it, you've bought it. And you've bought it because it gives you that feeling of being positive and lovely and all that lot. So you see it, you buy it kind of almost instantly, because it makes you feel better. And because it makes you feel better, the behaviour is you buy it. So the thought is, oh, I like that. That's going to make me feel better. If it makes me feel better, I'm going to buy it. And that's the behaviour. I've bought it. So what we need to do is go back to thought, and straight at thought, you see it, you think, oh, that gives me that feeling of, oh, I need it. And then you need to go back to thought, can I afford it? What's it going to do? And then hopefully that stops you buying it. I mean, that's a very, very loose term. But if you can find a better way of explaining that to somebody, because people go, oh, none of that stuff really works. It's because they've never had explained it to them why it works. They've just had to be launched straight into it. And again, motivational interviews. So 7 and 8, I absolutely think it should be in everyone's toolkit on how to use. The others, you should just have an understanding of. Evidence-based behaviour change tools and techniques. So for those that include capability, motivations, opportunity and action planning that can be applied to behaviour change interventions. So when we look at then planning somebody's interventions, so going back to those toolkits that we've given, looking at social prescribing, the toolkits, health promotions, maybe just breathing activities, all of that lot, we need to look at kind of how we do that. So again, we look at goal setting. We use those SMART targets. We can use motivational interviews, which are then personal centered, those counseling techniques that kind of look at the motivations of behavior. So, you know, if you lost a couple of stone, how do you think you'll feel? Oh, I feel amazing for it. Great, well, hold that feeling. Social support and accountability, feedback and reinforcement, those environmental changes, implementations, so then getting to it, looking at those behaviours, and then looking at the cognitive restructuring, and then look at graded tasks, so enabling people to do it over a period of time. K22 is the concept and theory relating to engagement, empowering co-design and personal central approaches. So as we're talking to the individuals, as we're listening, as we're trying to problem solve with them, we're obviously going to engage with them, and we want it personal centered, because the more they collaborate with us, the more it is that they're likely to change. So if we think about the theories of social change, from contemplation, thinking about it, to actually doing it, we need them to buy into it. There's no point us prescribing a treatment or a referral if they don't want it. So we need to listen to them. And here you've got the engagement model of change. So really recognizing that there. So empowerment. So empowerment individuals, enabling individuals to take control of their health and well-being. So looking at self-confidence, self-effective efficiency, looking at the autonomy and about making choices. And then again, you've got some other ones on there, the personal-centered approach. And again, you can't really go wrong with personal-centered approaches, because it is listening to that individual, taking into account everything that they're saying and wanting about their care. So look at your personal-centered approaches. It takes into account their values, their belief systems, and the decision-making process. The differences between enabling people to make choices and solving their own problems. And obviously, we don't want to be encouraging dependencies. So we need to, there is a difference between enabling people to make their own choices and solve their own problems and encouraging dependency. Enabling people to make their own changes and solve their own problems and encouraging dependency kind of looks at two distinct approaches in supporting individuals in various aspects of their life. So understanding the difference between these approaches is essential for healthcare professionals, educators, social workers, and people working in community health and wellbeing. And that's to provide effective and empowering support to individuals. So let's explore those concepts. So if we look at enabling people to make their own changes and solve their own problems, so there's a therapy called solution-focused therapy. Now, you know what I'm going to say? There is a course in course books on the mental health nurse where you can do solution-focused therapy. It gives you the techniques to understand how to help somebody solve their own problems. And that's about really providing them maybe with a balance sheet, allowing them to speak out their problem and then look at the resources to help manage their problem. And then they have that self-determination, and we can teach. And again, if you want to go to the YouTube channel, we teach on the YouTube channel problem solving skills, resilience skills, empowerment skills. We teach all of those coping skills. We teach a whole heap of skills that you could use with individuals to help them enable and promote their own health and well-being. So skill building, so looks at kind of what we've just said. Providing that supportive environment is really important, and a collaborative approach. So working with them, so look, do you think this will work for you? Do you not think this will work for you? Because there are so many choices about what we can and can't do. What we don't want to be doing is encouraging dependency, and that occurs when we kind of take away that and we find the solutions for them and we do everything for them, and inadvertently we kind of de-skill them. So we kind of overprotect them, we take away their responsibility, and it becomes like a real power imbalance. So it is about striking the right balance, and it's crucial that we get the balance right, because we don't want to encourage self. We don't want to encourage that. We want to encourage self-sufficiency. And to do that, we need to promote their independence. We need to offer guidance. We need to foster self-sufficiency, and we need to address any barriers. So in conclusion, we need to enable individuals to make their own we need to encourage people to make their own choices, solve their own problems, and empower them to make changes. We need them to build resilience. We need them to develop those problem-solving skills. But on the other hand, we don't want to encourage dependency. So again, you can use the YouTube channels that's there. We teach all of those things. We can say to them, look, I can do this with you. Here's the channel. I want you to look at solution focus. I want you to look at problem solving. And then it might be that, so last week we talked about this. You said to me you had a problem. Did you watch the problem solving video? You did, good. What do you now think? So we need to make sure that healthcare professionals, educators, and support workers should adopt a person-centered approach. So your behaviours, so your skills, knowledge, and behaviours, it's about being respectful for others. So again, I've put kind of what respectful for others looks like. You shouldn't just be doing this in this duty. You should be doing this all the time. So it's been referenced to duty 5, but I would expect you to be respectful to others as an apprentice all the time. It's a given, right? And being respectful for others basically means demonstrating respect towards individuals, colleagues, and communities is crucial, fostering that positive relationship. You need to collaborate that problem-solving solutions, the importance of being respectful with others. So that's about dignity and empathy, cultural sensitivity, effective communication, inclusivity, collaboration, personal-centered approaches, professionalism, conflict resolution, equality and fairness, and those ethical considerations. So being respectful with others is a fundamental value in public health practice, by showing respect towards individuals, colleagues, and communities. You should also be non-judgmental regarding other people's circumstances or decisions. We can be non-judgmental by, again, showing empathy and understanding. understanding diverse perspectives, trust building, being non-judgmental, being non-discriminating, working in a personal-centered way, understanding mental health support, social determination to health, being non-judgmental, cultural sensitivity, a collaboration, and again, those ethical considerations. And we then move on into our skills. So bear with me. So you can now see that you've got a case study here. Behaviour science plays a pivot role in helping people to identify and implement practical solutions to achieving better health and well-being. Duty 5 emphasises the application of behaviour science principles, in particular fostering behavioural changes, and enhances decisions and improving the overall quality of life. This essay will explore the significance of applying behavioural science in promoting health and well-being, more focus on practical solutions and their impact. So here you've got an essay question. I've kind of given it to you. You've got to cover the understanding of behavioural science, behaviour changes, some practical solutions, and look at overcoming barriers and the impact on health and well-being with a conclusion. Once you've done that, just upload it, and then I will see you back for the next session, which will be session 5, skills.